Things we move to the next speaker, Dr. Arnold Seto, and the title will be Coronary Imaging.
All right, good morning. In 8 minutes, I'm going to try to update you on the latest on coronary imaging, and it's appropriate that I follow Dr. Samadi, because I think actually the most important changes in coronary imaging have actually revolved around physiology. We know that there's physiological registration. There's also angiographic FFR, IBIS, OCT, NearInfrared. I'll try to cover all this briefly in about 8 minutes' time. But importantly, we know that there's anatomical and physiologic mismatch in up to 50% of cases, especially in the left main, proximal LAD, and left circumflex. So the ability to correlate the angiogram with the amount of physiologic abnormality at that location has become critical. And really, with the FFR wire pullback or catheter pullback, you can determine which of these lesions in the coronary artery is the most significant, and therefore which needs to be stented. In this case, the most critical area is the mid-RCA. Just as important is that this co-registration and the pullbacks allow us to differentiate between focal and diffuse disease, understanding that our stents really are best used to treat focal disease and are less appropriate for diffuse disease. So in the left-hand side, you see that the IFR changes the most into osteal LAD, and a short stent there will suffice, whereas in the LAD on the right-hand side, you would either need several overlapping stents, or this patient actually might be better off with a surgery, a CABG, so that it ignores the entirety of the diffuse disease. So I think the more I do these pullbacks, the more I realize that the underlying assumption of all CAD, which is that it is a diffuse process, is not necessarily a focal process in many cases, which is kind of scary because in FFR we like to think that we can take patients away from surgeons, but it might be that we might actually give some back when we discover that more of them are having diffuse disease. What about angiographic FFR? This is a remarkable advance in technology where you can take an angiogram, a 2D angiogram, and make a 3D reconstruction, and then simulate what would happen with hyperemia and get a simulated FFR. And this is sort of originally a pie in the sky. It's been worked on for over 10 years, but as of 2 years ago, they came very close with a correlation value of R value of 0.81 to get within 0.1 of the FFR measured. And so this study from Tu et al. Suggested that angiographic FFR was not just possible, but potentially accurate. The CathWorks protocol was presented last year at TCT, and they take a 10-inch image without any panning of the coronary angiogram, make a 3D reconstruction, and again try to calculate what using computational flow dynamics, what the FFR would be. And if you look at the original study from Tu, they got within 0.1 of the measured FFR. Well, with CathWorks, they get within 0.05 of the measured FFR. And in press right now is a study by Morris et al., and they're getting closer and closer. Now we're getting down to the 0.01, the 0.02, which is really nearly the effective divergence of repeated FFR measurements. So they're getting more and more accurate with angiographic FFR. So the concept would be you take an angiogram, you let the machine work on it for 3 minutes, and it gives you an FFR of the lesion you had in question, potentially obviating the need to use a pressure wire or pressure catheter. So that's very exciting for those of us in physiology. What about moving on to IBIS? We know that IBIS is associated with significantly lower rates of MACE, death, MI, and stent thrombosis, and target lesion revascularization across multiple studies, randomized and observational. The most recent observational study being the ADAPT-DES study, which showed that IBIS use was associated with a lower risk of MACE and stent thrombosis. And the most recent randomized study being the IBIS XPL study, showing a reduced incidence of MACE as well as TLR. Well, nothing's unfortunately occurred with IBIS for over 10 years until recently, where they developed the high definition or 60 megahertz IBIS, whereas normally the IBIS is 40 megahertz and has a resolution of 150 millimeters. The HD IBIS has a resolution of approximately 40 to 60 millimeters, and therefore it gives better pictures, and better pictures may allow you better imaging. So this is one example of how the new HD IBIS catheter works. It has a maximum pullback speed that's relatively quick. It gives excellent images, as shown in these pictures. You can better delineate the differences between the adventitia, the media, and the intima with these HD IBIS pictures, and they correlate well with anatomy. So just to show you side-by-side comparisons, these are different arteries, but 80% of the market is still phased array IBIS. And rotational IBIS in itself, from Boston Sci or Volcano's Revo catheters, inherently seems to have a better picture, a better quality image. Well, the rotational IBIS with the HD is even more superior, in my opinion. And as you can tell, the the pictures just visually look better, and that's what we're looking at for all coronary imaging. Whether that translates into outcomes is an open question. So in this side-by-side picture of the same artery, 60 megahertz of IBIS using a dual frequency catheter showed improved detection of plaque rupture. So you can see the underlying plaque more clearly than with the 40 megahertz. And in this set of pictures from HD IBIS, you can better delineate a dissection. In the lower right panel, you can clearly see the dissection flap, whereas in the lower left panel, you can barely see it with the 40 megahertz IBIS. So this is very exciting to have a new tool that finally improves IBIS to nearly the level of OCT. But there's still OCT, which has the highest resolution because it's a light wave as opposed to a sound wave. The actual resolution here could be anywhere from 12 to 15 microns. And but of course, with the caveat is the higher frequency, the more resolution you have in the near field, the less image depth that you have. So you don't get to penetrate into the lesion itself. So 3D OCT is another version of this. You can take the OCT that you see on the right here, which shows a little bit of malapposition. You can convert that with using computational image analysis into a 3D image, which then also has some special parameters to help you delineate where there's stent malapposition. In this case, coding green where the stent is well opposed to the vessel wall, and coding red when there's more than 2 millimeters of malapposition. Here's another version of OCT, which allows you to co-register FFR and OCT images with the angiogram, and you can see here a very complex set of images that allowed this case report to demonstrate that the implantation of a Triton bifurcation stent was optimized with the use of both FFR and OCT. And the resolution here is still astounding. Again, you can actually see the guide wires in the lower right with the hash signs are actually the guide wires used in the different vessels. So what about the actual clinical outcomes, though? And those still remain to be seen. The most recent trial was the Illuminion 3 study, which enrolled 450 patients and randomized them in a three-way trial to either pre-PCI OCT, pre-PCI IBIS, or pre-PCI angiography alone. Everybody got a post-PCI OCT, but for the IBIS and angiography group, they were blinded to the investigators, whereas the people in the OCT group, the investigators had an opportunity to improve upon the OCT findings. And what they found was that during the primary endpoint, there's no difference in minimal stent expansion or extent of optimal or unacceptable expansion. So there's no difference there compared with IBIS, but both were superior to angiography. However, OCT did show a reduction in the number of untreated dissections with a significant value against IBIS and a highly significant value against angiography. So especially in major dissections, these were reduced with the use of OCT. Malapposition, stent malapposition was reduced with OCT compared with IBIS and angiography. So these are two surrogate endpoints for what may lead to later TLR or later MACE. And so the conclusions from Illuminion 3 was that it was superior to angio-guided but not inferior to IBIS-guided PCI for achieving stent expansion, and resulted in the fewest untreated major dissections in areas of major stent malapposition. It did cost more contrast, about 30 mLs of contrast, and the clinical outcomes will be pending a larger trial such as Illuminion 4. What about near-infrared spectroscopy? You can take a near-infrared image and get a roadmap of what the lesion looks like using spectroscopy. The near-infrared catheter is mounted with an IBIS as well. The near-infrared has been correlated with an anatomy to show that a high lipid-rich plaque it can be detected and is measured by the lipid core burden index, LCBI. The color registry was a 1,900 patient registry which tried to determine whether stenting of these lesions, which are lipid-rich plaques, was it associated with more MACE. And there was concern that when you stented across these lesions, you'd have more incidence of no reflow and more incidence of MACE as a result. Surprisingly, though, to the investigators, there was no significant difference between the content of the lipid plaque and the prediction of MACE. And in fact, the hazard ratio was slightly less with the high MACE, the high lipid-rich plaques. If you try to determine the relationship between NEARS and culprit-related MACE, there's actually almost no predictive value here. So unfortunately, for this technology, it doesn't seem to be predictive of MACE, but a larger study, the Prospect 2 study, is testing NEARS for this application. Future prospects, something that we heard about down the road from us was that they're trying to use a special wire, an impedance guide wire, that can do both fractional flow reserve pressure measurements, but also give you a cross-sectional area, using electrical impedance to actually give you equivalent of an IBIS, a cross-sectional area of the artery. And theoretically, you can combine all three of these tools that are currently used at $1,300 and combine them into $600 for a single wire. And at least in their lab data, they show the high repeatability and potentially a within 10% correlation with IBIS. So I'm going to skip my last part, but in conclusion, the future of imaging is very bright, but the true clinical outcomes are going to be in the measure, and some of those are still pending. Thank you very much.